Hi, everyone, and welcome. If you're signed on to the Youth Sports Injury Prevention Program we have planned for tonight, partnered with House of Sports and ONS. We'll give everyone just a few more moments to sign in and get started just at 7 o'clock. Thank you again for joining us, and we appreciate your patience. So again, welcome everyone, and thank you for joining our Youth Sports Injury Prevention Program tonight. My name is Frank Lombardi, and I am the General Manager at the House of Sports. For any of you who have not visited the House of Sports, we are a 100,000 square foot facility in Ardsley, New York. The physical plant consists of 4 basketball/volleyball courts, an 80 by 40 yard turf field, a baseball training area, fitness studios, and a cafe. We focus on sports training and programming for children 2 years old through high school, as well as programming like tournaments, leagues, camps, parties, events, and rentals. Tonight, we are hosting a youth sports injury prevention program with experts from our orthopedic partner at ONS. For those of you not familiar with ONS, ONS is an advanced multi-specialty orthopedic and neurosurgery practice that has served patients throughout Connecticut and Westchester County for more than 25 years. We are very excited now to introduce our presenters from ONS. First, ONS Orthopedic Sports Medicine Surgeon, Dr. Marc Kowalsky. Next, Primary Care Sports Medicine Physician and Concussion Specialist, Dr. Ben Greene. And finally, Doctor of Physical Therapy, Dr. Crowe. Thank you all again for joining us tonight. Like I mentioned, tonight's topic focuses on injury prevention in youth athletes. At House of Sports, this is a particularly important topic for us, as we always put safety of our customers at the forefront, and to have 3 great experts tonight to share with us in this field is fantastic. Before we get started with the speakers, if you have any questions during the talk, please put them in the chat, and we'll do our best to get to as many questions as possible after each speaker. With that, let's look to get started. Please join me in welcoming our first speaker, Dr. Marc Kowalsky. Dr. Kowalsky is a board-certified sports medicine surgeon. He completed 2 subspecialty fellowships, the first in sports medicine at Lenox Hill Hospital Nichols Institute of Sports Medicine and Athletic Trauma, and the second in shoulder and elbow surgery at the Washington University School of Medicine. He has expertise in the surgical and neurosurgical management of sports injuries for the shoulder, elbow, and knee, He treats complex shoulder and elbow conditions, including degenerative disease, trauma, revision surgery. He has particular interest in the management of shoulder and elbow arthritis, instability, ligament and tendon injuries, as well as knee, ligament injury, and cartilage disorders. Dr. Kowalsky sees patients at ONS locations in Harrison, New York, Greenwich, and Stamford, Connecticut. Dr. Kowalsky, thank you again for joining us, and take it away. Dr. Kowalsky, you there? Dr. Kowalsky? Dr. Crowe, can you hear me?
Yes, I can.
Okay.
Hey, everybody. I'm Marc Kowalsky. Thank you, Frank, so much for putting this all together, and to the communications and marketing team at ONS for collaborating with Frank and the team at House of Sports. I'm going to share my screen and get started. So I'm going to lead off with some topics from the physician and surgeon's perspective on preventing injury, and then Dr. Greene and Dr. Crowe will provide their perspective as well. I'll try to cover a few different topics along the way, and then leave enough time for questions, and then pass the podium on. There's an epidemic of injuries in young athletes that we are all aware of. And this is due primarily to significant increase in sports participation, with over 30 million kids participating in organized sports every year. 30% of these young athletes are highly specialized, as we'll talk about. They're specializing in sports at an earlier and earlier age. And the fact is that 3.5 million children under the age of 14 are treated annually for sports injuries. More than half of these injuries are overuse, and therefore, by definition, should be preventable. But one of the root causes of some of these overuse injuries in our youngest athletes is specializing at an earlier and earlier age. Sports specialization is defined as participating in intensive training and competition in organized sports for at least 8 months out of the year, participating in one sport to the exclusion of other sports, involvement of kids 12 years old or younger in this specialized approach, and as a result of this specialized approach, limited overall free play. One of our concerns is that the bones of these youngest athletes are still developing. They're quote unquote skeletally immature, where some portions of their bone are actually still made only of cartilage, where the growth plates are. These cartilage growth plates are a bit softer than bone and a bit more compliant, and therefore are more vulnerable to injury when subjected to repetitive overuse. Some of the risk factors associated with specialization are, first of all, year-round training that many of these kids and parents perceive as necessary to excel and be successful, repetitive, technical, high-risk mechanics for some of these sports, including our overhead athletes, and more competitive demands associated with specialization. So there's more frequent, intense formal competition in the case of tournaments, for example. And these competitions are associated with increased risk of injury. And combined with the competition is the other side of the coin, which is inadequate rest and recovery before the next bout of competition. What we know is that there is an increased injury risk with sports specialization at the youngest ages. If a young athlete pitches for at least 8 months out of the year, they're at increased risk for injury. If there's no break from one sport for at least one season out of the year, injury risk goes up. And if one specializes before the age of 12, the injury risk goes up. So it's important to pay attention to the injury risk of these youngest kids. As important as the injury risk is this concept of psychological burnout. When younger kids are subjected to the stresses that come along with specialization, the risk of psychological burnout and leaving the sport goes up significantly. This can manifest as a loss of intrinsic motivation to practice and train, lack of enjoyment of the sport, which is incredibly important for our youngest athletes, a high level of stress and anxiety in these kids who already have relatively ineffective coping strategies. And there's also a fear of re-injury in our youngest kids if they happen to sustain an injury at a younger age. There's a variety of other ways that psychological burnout can manifest that might be less expected. It can manifest as a true mood disturbance or mental health illness, such as depression or anxiety, isolation from one's friends and peer group, eating disorders, and finally, the feared dropout. Many of these kids will leave their sport altogether as a result of the increased intensity, perhaps at too young of an age. And then the other side of the coin, besides whether or not injury risk goes up, is specialization even effective in generating an elite athlete? Because that's why many of these kids and parents pursue this approach. They want to train and become expert at a younger and younger age in order to open doors for prep school positions, scholarships, admission to competitive colleges, and then, of course, professional and national team participation. The truth is, no matter how you look at this question in the literature, specialization at a younger age is not effective in generating an elite athlete. There's a variety of ways to look at this. You can look at countries that select kids at a young age and channel them to academies to participate in national teams like China and Eastern Europe, for example. When you look at kids that are chosen to specialize at a younger and younger age, they don't reach elite status more than their counterparts who were diversified in their sports participation. Another way to look at this is to identify elite athletes that are playing professionally or participating in a national team and backtrack. And when you do this, similarly, you find that these athletes were more likely to have diversified at a younger age, which may have played a role in allowing them to become elite. A final way to look at this is to identify kids who actually diversify, play multiple different sports before the age of 13. These kids, the diversified kids, rather than the specialized kids, were more likely to reach elite status later in life, possibly due to the lower likelihood of psychological burnout and dropout. Well, what are the theoretical benefits of early diversification, as has been agreed upon by most of the governing bodies of national teams and professional organizations? There's, of course, enhanced physical literacy, the ability to be more limber and flexible and acquire new skills. There's a crossover effect where excelling in one sport, like lacrosse, might actually benefit your ability to excel in a different sport, like hockey, for example. You have an improved ability to develop complex motor skills. You also develop those important psychological and cognitive skills that allow you to cope with the stresses of competing at a high level. And then finally, the psychological well-being that goes along with being a diversified athlete. So what are some general protective strategies for our youngest kids if one chooses to diversify? First of all, and most important, provide opportunities for free, unstructured play. There really is no replacement, particularly for our youngest ages, for free, unstructured play. The ratio of weekly hours of organized sport to free, unstructured play should remain below 2-to-1. The weekly hours of sports participation in a structured sense should not exceed the child's age to a maximum of 16 hours. And if at all possible, avoid specialization before the age of 13. And then one of the important points that you take away from my talk and Kat's talk is the importance and safety of strength and conditioning, even in our youngest athletes. And that leads to the next point. There are a variety of benefits to a strengthening and conditioning program, and some of them are listed here, and perhaps Dr. Crowe can touch on some others. But there are some myths that make parents and children apprehensive in beginning a strength and conditioning program at the youngest ages. First of all, strength training, is it unsafe for children? The truth is, the risk associated with strength training is not any greater for younger kids than it is for any other athlete at any other age. Another myth, strength training will stunt the growth of our children. There's no current evidence that a supervised strength training program will negatively impact growth and maturation. Thirdly, children will experience growth plate damage as a result of a strength training program. Growth plate fracture has not been reported in the literature when a supervised and appropriately executed program is implemented. And finally, children can't increase strength because they don't have adequate hormonal balance, including testosterone. That's actually not true. Testosterone is not essential for achieving strength gains, although our oldest athletes will have a little bit of an easier time maintaining strength gains. The bottom line is that most professional societies, including mine on the surgical side, Dr. Greene's on the primary care sports medicine side, and I'm sure Kat's on the physical therapy and strength and conditioning side, all agree that strength and conditioning, when properly implemented, is safe and effective even for our youngest kids. The pearls are, it has to be supervised, appropriate to the patient's age and experience with a sensible progression, careful selection of equipment, limit heavy lifts, and allow adequate recovery between sessions. And now I'll move on to some of the other habits and routines that are important for athletes. One of the things we tell our higher level athletes at competitive high schools and colleges is what separates good from great for these athletes are habits and routines that lend to success and that help to prevent injury. So as we begin to talk about diet and hydration, these habits and routines become exceedingly important. This is what a general well-balanced diet looks like. The concept has evolved over time from the food pyramid to this pie chart, where carbohydrates should account for at least half of our calories, protein should account for about a quarter of our calories, and fat for a quarter to a third of our calories. I'll talk a little bit about how many grams one should get per day, but just as an example of how many carbohydrates we can get from a bowl of spaghetti, which is a very common source of carbohydrates and glycogen, 1 cup of spaghetti, which really isn't all that much, gives you about 40 grams of carbs. So we'll talk a little bit later about how many cups of spaghetti one might need. In terms of protein, which provides amino acid, which serve as building blocks for the muscle that we break down when we work out, train, and compete, we can get protein from a variety of different sources. We can get them from seeds, beans, and nuts. We can get protein from dairy products, cottage cheese, yogurt, and milk. And the more common sources of protein are our meats, fishes, and poultry. That's where we're really going to get the lion's share, anywhere between 20 and 30 grams of protein per serving. But you can change things up and have variety in your diet, or be vegan or vegetarian, and still get adequate protein in your diet. We should get some fat in our diet, even our elite athletes should, but it's important to make sure that our fats are the healthy fats. These include plant oils, seeds, nuts, avocado, chickpeas, and we want to avoid at all costs saturated fats and trans fats. It's a bit of a losing battle to convince a child to avoid processed foods and fast foods altogether, but we really want to limit these processed foods and fast foods as much as possible, perhaps except for, a treat or celebration, because it really isn't a part of an elite athlete's diet and won't be providing the fuel sources that they need to perform and stay injury-free. Some of our older athletes will begin to express interest in protein shakes. Protein shakes are an effective way to give amino acids to our body to rebuild muscle that we've broken down during a workout. It's perfectly safe and appropriate and can be an important supplement or meal replacement if necessary. If we're using it to rebuild muscle, we want to take our protein shake during what we call the anabolic window, which is in the hours immediately after a workout or period of exertion. Among all the protein shakes that are available, whey protein is the best. It's readily available, it's easily digestible, and appears quickly in the bloodstream. And it has leucine, which is important for muscle synthesis. Just like everything else we eat, I encourage our young athletes to turn the package or bottle around, read the label, and know what's in the product. If we're choosing a protein shake, we want it to be clean. We don't want it to be mixed with creatine and caffeine, and we want it to be relatively low in sugar. They tend to load these products up with sugar to make them tasty, but then it's really not giving you exactly what you need. So as clean of a product as possible with as much whey protein as you can get. Well, as important as what you eat is when you eat it. So meal planning is incredibly important for our high-level athletes. The first concept of meal planning is never skip a meal, and that begins with breakfast. Breakfast is the start of a healthy meal plan, and it will avoid muscle breakdown. If our athletes skip breakfast and head straight off to school, their body is going to need that glycogen as their gasoline fuel source, And they're going to start to break down muscle to find that glycogen to power the body during the early part of the day. So begin with breakfast and avoid muscle breakdown, and try to have a healthy breakfast that provides a nice balance of protein and glycogen. Here are some examples. Before we exercise, whether it's training or a match, game, or tournament, we want to have a meal no sooner than 1 to 2 hours before a bout of competition. And it should be a relatively small meal between 200 and 500 calories, easily digestible carbohydrates, because this is what's going to provide our fuel source to exert ourselves, and avoid high fat and high fiber. As important, again, in terms of habits and routines and knowing what you're consuming, our athletes should decide what works for them, what doesn't upset their stomach. Once they find out what works for them, they should replicate that every week in the case of a football player, for example, or every tournament in the case of a basketball player, because they know what will work for their body, won't upset their stomach, and will give them what they need. After competition, there should be 2 meals, one immediately after, 30 minutes or so, and another 1 to 2 hours later. The 30 minutes after should be a very small burst of glycogen and some protein, and that can be a nutrition bar, for example, orange slices, bananas with peanut butter. The meal 1 to 2 hours later should be their true meal, and that should be high in carbohydrate to refuel for the next bout of competition, moderate in protein to help rebuild muscle, and nutrient dense. So a well-appointed sandwich, a salad, yogurt with nuts and fruit are all good examples. Many people ask about energy bars and are they a good idea? And the truth is, it depends. There are bad energy bars and good ones. The bad energy bars are going to be loaded with sugar and won't have enough protein, and they're essentially a candy bar, and those are seen on the right panel. On the other hand, we want our athlete to turn around the package, look at the label. We want at least 5 to 10 grams of protein, no more than 10 to 12 grams of sugar, heavy in seeds, nuts, peanut butters, whole grains, and dried fruit. So Kind bars are a really good example of a healthy, effective nutrition bar. In terms of hydration, incredibly important for our youngest kids. By the time they walk out to the field, or by the time they get driven to House of Sports for afternoon training or nighttime training, 3 out of 4 of these athletes are dehydrated. And that's a problem, because if you lose 1% of your body weight only, it negatively impacts your performance. And if you lose 3% of your body weight, you're at risk for heat illness. So this is what timing of hydration looks like. 1 to 2 hours before you play, 1 to 2 cups of water. Right before you play, 1 more cup. During exercise, a half a cup to a cup every 15 minutes. And then 2 cups for every pound of water lost over the course of the game. Similar to energy bars, there's a question about whether sports drinks are a good idea, and the same answer: it depends. They are effective to replace nutrients and carbohydrates, but you want to make sure it's not loaded with sugar. Most of them are, but you don't want any more than 6 to 8% carbohydrate. To be honest, diluting Gatorade or Powerade by half is a good idea, or using one of the electrolyte replacements for endurance runners like Tailwinds or Liquid IV is another great way to replenish carbohydrate and electrolytes without excessive sugar. So just some quick hits on diet again, and now with some numbers filled in for our typical high school athlete. 300 grams of carbs over the day, 90 grams of protein over the day. Focus on healthy fats versus processed foods, nutrition bars that have less than 12 grams of sugar and at least 5 grams of protein. And if you're going to use a protein shake, a whey protein shake during the anabolic window. For hydration, 2 to 3 cups before you play, 1 cup immediately beforehand, 1 cup every 15 minutes while you play. And sports drinks are really only essential if you participate for at least 1 hour. Otherwise, there really is no role other than tasting good and making hydration a bit easier. Sleep is a bit of a losing battle, but it's as important as diet and hydration. Our high school athletes should be getting 8 to 10 hours of sleep, but that's virtually impossible with school, homework, club sports, high school team sports. But we try. We strive for 8 to 10, and we get as much as we can get. As important as the amount of sleep is the quality of sleep. And we can improve our quality of sleep by paying attention to what we call sleep hygiene. We eat consistent meals and stay well hydrated. Avoid regular extensive napping. Short naps are fine. Don't lie awake in bed for a prolonged period of time. If it's not working, our athletes should get out of bed, break up the routine, and try again in 10 to 15 minutes. Avoid physical activity right before bed, avoid screen time right before bed, try to wind down gradually to allow yourself to fall asleep easily. And finally, I just wanted to touch on the role of mindfulness in the elite athlete. Most of us know what this means at this point in time, but it involves being present and non-judgmental about oneself, even in the most unpleasant and painful moments, which oftentimes happen on the court. The goal is not to change problematic thoughts, but instead to accept them and move on. Who are the athletes that meditate? Well, to be honest, most of the elite athletes incorporate mindfulness to some degree. There's this concept I borrowed from one of our sports psychology partners in the community of Janus. He's a Greek god who is characterized by this sculpture of a head looking both backward and forward. And this is really what torments our athletes. They very rarely live in the present. They're oftentimes being self-critical about the play that just occurred and being anxious about the play that's about to occur. And this negatively impacts their performance. Okay, so we want to teach them how to take a pause and control these negative thoughts. The truth is, it's not only about what's happening on the court. Their entire life is full of stressors, and we want to provide pauses during other aspects of their life that can impact their happiness, well-being, peace of mind, and then their ability to perform and enjoy themselves in sport. So as athletics, academics, and life gather stress, incorporating a pause with mindfulness and meditation can help them to regain focus. There's proof in the literature that mindfulness helps athletes in the following ways: improves decision-making on and off the court, reaction time, distractibility, and concentration for those sports that require it, improves agility, improves, of course, sports-related anxiety in the toughest moments, and improves the so-called flow state, where they can perform better in an effortless way. And there's data to show that it decreases injury risk, which is the topic of this presentation today. Lower injury risk, improved injury recovery time, and improved individual and team performance in the context of soccer, at least. So in summary, most of our athletes have talent. All of them are training hard. What separates good from great are paying attention to the concepts outside the lines of the court and field, which include sleep, fuel, hydration, and mindfulness. And then Dr. Greene and Dr. Crowe are going to touch on some of the more specific injuries that our athletes encounter and how to avoid them. So thank you very much.
Oh, that's a lot of excellent information there. And I think, another thing to touch upon there is that forming these good habits as a youth athlete, not everyone's going to go pro. We do our best at House of Sports to get you to play at your modified team, your high school team, and hopefully at college. But building these good habits as a 7, 8, 9, 10, 11-year-old, hydration, eating right, responsibility, time management, if you don't go pro, helps you in the corporate world or wherever you take your career. So I think a lot of good information there as well. One quick question we had in the chat, which I think we can get to quickly. I apologize. This comes from someone says, I have a 10-year-old son who plays multiple sports but focuses on soccer as his travel sport. Should he be on a strength training program? If so, how much is too much weekly that he should be training? Specifically to, I think they're speaking to the strength side of things.
Great question, and we are often asked about it, and I'm sure Dr. Crowe will have some more feedback on specifics of strength and conditioning. I think that in a perfect world, all of our athletes who have an interest in excelling in their sport, and it sounds like this particular individual does, I believe should be participating in a strength and conditioning program. The truth is, at the younger ages, it doesn't have to involve any barbells and dumbbells. A lot of it will be body weight exercises, and at the most bands and agility and core strength. But there are certain exercises that can be perfectly safe and appropriate for a 10-year-old and actually allow them to mitigate injury risk and excel. It's hard with an already packed schedule, and it sounds like already playing multiple sports, perhaps multiple teams at the same time, to do a whole lot with strength and conditioning. But perhaps once a week dedicated to just learning skills would be helpful. To your point, it's really not about them becoming elite in the gym. It's about learning life skills so that when they do have time to commit to a true strength and conditioning program, they're already one step ahead.
Yep. No, that's a great answer. Thank you very much. So let's move along here. Our next speaker is Dr. Ben Greene. Dr. Greene is double board certified in both primary care sports medicine and pediatric medicine. Dr. Greene specializes in the non-operative management of musculoskeletal injuries in adults and children. He has advanced skills in ultrasound-guided injection, dance medicine, and concussion management. Dr. Greene graduated from the University of Wisconsin with a bachelor's degree in human development and family studies. He received his medical degree from Tulane University School of Medicine and completed his pediatric residency at New York Presbyterian Columbia University Medical Center, JP Morgan Stanley Children's Hospital, followed by fellowship training, primary care sports medicine at New York University Langone Health. Dr. Greene, thanks again for being here tonight, and the floor is yours.
Thanks so much, Frank. Really appreciate the opportunity to be here. And again, thank you to ONS for collaborating. And thank you to Dr. Kowalsky for that phenomenal overview, chock full of really good nuggets and really informative. So great talk. So I'm going to switch gears and just kind of get a little bit more focused in on concussions in the youth athletes. As Frank mentioned, I am the director of our Sports Concussion Center. I do see a lot of pediatric and adolescent concussion patients. And so I wanted to speak a little bit about, what goes into my evaluation and how I view management of concussions in the youth athlete today. So nothing to disclose. So we'll talk a little bit about how I like to define concussions. We'll talk about how common they are, how they typically present in terms of their symptoms, what does diagnosis and management look like, and then what does recovery look like. So if you Google what is a concussion, you're going to come across half a dozen to a dozen differing definitions, and a lot of them are going to be extremely wordy and sometimes confusing and a little redundant, and it's just as likely to confuse as it is to educate. So I like to try to simplify. Whenever I see patients in the office, the first part of a concussion evaluation is always talking about what exactly a concussion is. I think there's a lot of misinformation out there, so I think it's important to kind of clarify and simplify things. So one definition that I've come across that I like and I appreciate for its simplicity is, so it's you can think of it almost like a bruising injury to the brain, and the brain is the central processing unit for the body that we start with the signals being decided in the brain, and then those signals are sent everywhere throughout the body to our different systems like our eyes and our hearing and our movement and things like that. And so what happens with a concussion is those signals are still firing, they're just much slower, and it will take a lot longer to get from point A to point B. And as a result of the slowing of the signal propagation or those signals moving around the body, people develop all of these different symptoms. So I also like to describe a concussion as a functional injury as opposed to a structural injury, right? If someone falls and breaks their arm, we have an x-ray, we show a clear break, right? That's a structural injury. That's easy to grasp. I think concussions are a little bit more complex and abstract because, as is often the case, there is nothing seen on imaging, which is why we typically don't recommend any imaging, including CAT scan or MRI for concussion management. But rather it produces these symptoms that impair with various functions throughout different domains of life. And so I like to kind of even simplify it a little bit further, right? So think about getting to work. Let's say you drive on 95 or the Sawmill to get to work, right? And on a clear morning, there's no traffic. You're getting to where you need to go as quickly as humanly possible, and everything is nice and easy, right? So when there's a concussion, there's a traffic jam somewhere. So you'll still get there, you'll still get to your destination. It's just going to take a lot longer. So I like the traffic analogy. I think it really helps to kind of simplify and help people understand exactly what they are experiencing. So in terms of how common concussions are, admittedly, the true numbers are a bit of a challenge for a number of different reasons. Historically, there was a lot of underreporting of concussions. We have gotten a lot better about that, which is fantastic and has led to an increase in diagnoses. The other major contributing factor is, if it is reported, there's a lot of different places where patients can present with concussions. Some will go to me, some will go to their pediatrician, some will go to the emergency room, some will go directly to physical therapy. And as a lack of, because there is a lack of one unifying central gathering source, a lot of the data is lost and we don't have all of that available to us. However, given our best estimates, we estimate that there's about 1.6 to 3.8 million recreational and sport-related concussions that occur annually at all ages in the United States. And then if we break that down further for our younger athletes, our 18 and younger, there's an estimated 1.1 to 1.9 million patients per year. Now, this data is already 5, almost 6 years old. I'd be willing to bet that when the new census come out, the numbers are going to be even higher than that. So in terms of what to do when there is something, an event occurs and there is concern for a concussion. So most of the time, with sport-related concussions, right, it's going to occur at a game, at a practice, could happen wherever, in the backyard. So one of the reasons why concussions are challenging is because sometimes, a lot of times, it's not very obvious when a concussion occurs. There will be instances where there will be a very obvious hit to the head. Potentially it results in a loss of consciousness, right? That's a very easy diagnosis. But the majority of sport-related concussions do not result in any loss of consciousness, and there's really no frank neurological signs. The other diagnostic challenge for any providers or parents that are kind of evaluating for these types of things is that there really is no one best test for a concussion. If we can wave a wand over someone's head and it would tell us, yes, concussion, that would make our jobs a lot easier. But unfortunately, that test doesn't exist. So we rely on a multitude of different questions and exam maneuvers and neurological testing to make a kind of split decision in that moment. Do we think that there was a concussion that occurred or not? In situations where there's a clear concussion, or if a concussion is suspected and that person cannot be ruled out by someone with expertise, the absolute most important thing is that that athlete should be removed from play and not allowed back into the game that same day. If there is one thing that comes away from my talk, it's that. If there is a concern, if there's whispers of it, and there's nobody who can say definitively that, no, this was not a concussion, the safer thing is to err on the conservative side and keep kids out from play. So in terms of what I'm looking for when I'm evaluating athletes in the setting of a head injury or potentially a whiplash mechanism, right? There are a number of different ways that people can sustain concussions, direct blows to the head or whiplash mechanisms being the two most common. I'm basically forcing myself to answer two main questions. One, does that person need to go to the emergency room or not? And the way that I'm answering that question is the presence or absence of any of these red flags. So I think it's very important for the community to know what these red flags look like. One of the most common questions I get from people who are calling the office to schedule a concussion evaluation with me is, do they need to go to the emergency room first? And so my answer is always, if any of the present are following, then yes. And if not, then it's not necessary. So I do think it's important that everyone has an awareness of red flags. So red flags consist of, if there's any neck pain or tenderness, this could potentially signify that there might be an underlying cervical spine fracture or a skull fracture. Those would be red flags, and that would warrant emergency room evaluation. Some other obvious signs, if there is a seizure or convulsion, we need to go to the emergency room. If a person is reporting double vision right away, or if there's loss of consciousness, those are very clear-cut signs as well. Now, if they report weakness or tingling or burning in greater than one arm or in the legs, that would be a red flag. I think the important distinction here is that there is another condition that's very common called a stinger that will produce potentially weakness and tingling going down one arm, but that is not considered a red flag injury. That can be observed on the sideline. They should still be held out from play, but that would not be a situation where someone needs to go to the emergency room. Other situations like that are concerning, right? Red flags, if there's a deteriorating conscious state, if there are multiple episodes of vomiting, and vomiting is a little bit of a controversial subject. A lot of people would agree, most would agree that one episode of vomiting, not necessarily a large concern, but if there's 2 or more, we shouldn't take our chances and we should send to the emergency room in that situation. If they are reporting a severe or worsening headache, if they are very restless or agitated or combative, that can be a subtle sign that sometimes there's something potentially dangerous going on. And a lot of times as the sideline provider, we don't know all these kids, at their baseline. So we don't know their typical personalities. So these are situations where it's very useful to get, have other players or coaches weigh in and say, hey, no, that's not what he's normally like. This is atypical for him or her. And in which case we need to take that seriously. And lastly, of course, if there's any visible deformity of the skull, that needs to be taken very seriously and they need to go to the emergency room. Now, in the absence of any of those red flags, typically emergency room evaluation is not required. So that's the first question I'm asking myself. The second question I'm asking myself is, do I think they had a concussion or not? And like I said before, if I feel very strongly or if I suspect, but it's a little bit ambivalent, I'm ruling them out for that day, and I am erring on the side that it was a concussion. The other important thing that I think is important for the community to be aware of, a lot of symptoms from concussions are more obvious, right? People will say headaches or dizziness or lightheadedness, right? Those are some of the more common ones that we get. But there's a lot of symptoms that people can present with, and some of them are more subtle than others. So I do think it's also important for people to be aware of all of these possible concussion symptoms, because someone might only present with some of the more subtle and atypical ones, and that might be the only sign that there was a concussion in the event that there was no specific trauma that the patient or their parents can recall. So these symptoms, which I always go through at every single visit with all of my concussion patients, and I'm having them constantly grade and regrade so that I can get updates on the development of these symptoms and how much they're experiencing them or not. I think it's very important for people to be aware of the kind of vast variety of symptoms that people can experience. So symptoms that people can experience include headaches, pressure in the head, neck pain, nausea or vomiting, dizziness, blurred vision, balance problems, sensitivity to light and noise, feeling slowed down, feeling like you're in a fog, a sensation of just not feeling quite right or feeling off, difficulty concentrating or difficulty remembering, fatigue or low energy, confusion, drowsiness, feeling more emotional, feeling more irritable, feeling sad, feeling nervous or anxious. A lot of these affective symptoms are the more subtle ones and sometimes don't come on until even a time removed from the initial injury. So I think very important to keep that in mind as well. And then we know that concussions can also affect sleep, and specifically can affect the ability to fall asleep. So I think it's useful to kind of go through a brief overview of what entails my evaluations so that we can get a better understanding of what exactly we're looking for, which helps to then shape our management for concussions in youth athletes. So as with all other injuries, we're always starting with getting some history about the event, right? So what happened? When did it happen? Was there a loss of consciousness? Does that individual remember everything both before and after, or is there some amnesia surrounding the event? Has the individual ever had a concussion before? When was the last concussion, if so? And what did that recovery look like? Did it take 4 days to recover? Did it take 3 months to recover? That's very important information for me that potentially helps to shape my expectations for how that individual's concussion may progress. I'm also assessing for underlying comorbidities or other medical conditions that potentially can affect the prognosis for each concussion. Things like learning disorders, ADHD, developmental disorders, mental health disorders like anxiety, depression, OCD, a history of migraines, as well as do they have any visual aids? And interestingly enough, I'm asking about these conditions in both the individual as well as is there a history of these conditions in the family? Even if these conditions are not present in the individual, if there is a positive family history, potentially that can still affect that individual's progression as they recover from a concussion. And then when I say symptom inventory, that's me referring to all of those 22 symptoms that I mentioned and went through on the previous slide. And I'm going through all those and having them grade them for me. And lastly, I'm also figuring out, do symptoms get worse when you're physically exerting yourself and or when you're mentally exerting yourself? Now, moving on from the history, there's always a physical exam component, of course. First and foremost, I'm always checking a neurological exam, make sure that there's no gross neurological deficits that would warrant going to the emergency room straight from my office. That is very rare. I'm also palpating or pressing on the head and neck to make sure that we're not missing any subtle signs of any possible skull fracture or neck fracture. And then I'm also going into a little bit of a more nuanced examination where I'm examining the eye system and the balance system. And I'm checking for, is there any dysfunction of any of those symptoms or of any of those systems, which are very commonly seen after concussion. I'm evaluating that through a different number of different tests and kind of asking questions about their cognition, testing them a little bit. I always like to kind of phrase it as we're playing some brain games to help to better understand our concentration and memory and our orientation about things. And so after going through and collecting all of that data, that then helps me to summarize and help to characterize each individual concussion, because no two concussions are the same, and each individual needs to be taken as their concussions are presenting. Now, in terms of what we expect for what's normal versus what's normal, the typical recovery timeline is that an individual will sustain that injury. There's going to be an initial worsening of symptoms. Then they're going to plateau, and they're neither going to get much better nor much worse. And then a lot of people describe this sudden turning of a corner, and then they rapidly improve after that. And so what we expect is that this timeline will differ depending on a person's age. Adults, usually 18 and older, they're going to take less time, anywhere from 10 to 14 days. One of the most important things that people are surprised by to hear often is that children, so 18 and younger, it's actually considered a normal recovery to take up to 28 days. And that is still a normal recovery. So, a lot of people will come in 2 weeks after an injury. They're very nervous that their children are still having symptoms. And a lot of the times it's just reassurance and more time and patience, and those symptoms will go away on their own. Now, in terms of things that can be done at home immediately afterward that are proven to help speed up recovery, Dr. Kowalsky talked a lot about sleep and hydration. Those are paramount, and those are things that I always talk about, right? Emphasizing proper sleep hygiene goes a long way, making sure that we're getting adequate number of hours per night, avoiding napping and really trying to cluster the sleeping at night is actually more restorative than getting in an hour or two of napping during the day. Staying well hydrated and getting that proper nutrition is paramount for the brain to recover from its injury. So sleep, hydration, and proper nutrition, absolutely very important. Now, breaking it down and getting a little bit more granular, let's say that there's an event over the weekend, right? There's no red flags. There's historically been a trend of this notion of cocooning, right? So where previously, when we didn't know better, what we would recommend is that, we kind of put these individuals in a dark room and we tell them to avoid any stimuli, no schoolwork, no chores, no screen time, just stay in the dark room and sleep. And then there's a worried parent checking in every 30 minutes and rousing them awake and still making sure that they can wake up. And what we know now is not only is that not helpful, but that actually can be harmful and can slow the recovery from concussion. So without a doubt, I recommend avoiding that cocooning, okay? 24 hours of relative rest, absolutely appropriate, right? So basically I tell people just chill out, okay? We don't need to have any strict rules about absolutely no screen time. That's becoming increasingly more difficult as we become more reliant on screens and technology. So I like to take a bit more reasonable approach everything is based off of their symptoms, right? So a little bit of screen time here and there, not going to aggravate things substantially. The other thing that can be very important, and I always do recommend, is some light physical activity. So there's this notion of subsymptom threshold light physical activity, basically going out on a walk or hopping on a stationary bike, getting the heart rate up a little bit, but not necessarily even breaking a sweat, just going a little bit, doing a little bit of activity, pushing the individual up to the brink of their symptoms getting worse, but not to the point where they are becoming very symptomatic, can help to speed up recovery. So then with student athletes, I always tell them you're a student athlete, emphasis on the student, right? So the most important criteria for me is always making sure that they get back to school properly and that they are firing on all cylinders and they're not needing any academic accommodations. So we always go through in depth kind of what the return to learn process looks like. It's usually a gradual process, starting with some light homework at home, and then maybe a couple hours or a half day at school, or if they can tolerate it, then we like to try to be in school full time. I think a lot of people historically have said no school for a week or 2 weeks, and we know that actually slows recovery. So I do try to get people into school as quickly as we can. And sometimes it takes accommodations that I provide via forms that will help to kind of mitigate symptoms and keep student athletes remaining relatively symptom-free and at school and hopefully learning and retaining information that entire time. Now, once an athlete has returned to school fully and they have no further symptoms and they have a normal exam with me, then we always embark on this return to play protocol, which, similar to the return to learn, is this graduated, progressive, stepwise protocol that is usually helped to be overseen by school athletic trainers or coaches. Basically consists of 24 hours. Each 24 hours consists of an increasing amount of physical exertion, and we're monitoring for symptoms during the exercise as well as afterward. If they don't have any symptoms, they get to move on to the next stage. If they do have symptoms, that's okay. They just need to repeat the same stage the following day. And once we get them cleared all the way through this protocol, that's when it is safe to get kids back and fully to sports. So just going in a little quickly, I think I'm running a little bit over time, but in terms of management of concussions, like I said, no concussion is the same as any others, but we help to kind of manage by breaking them down into different categories based on what their predominant symptoms are. So we break these down by cognitive predominant symptoms, ocular motor affecting their eyes, headache or migraine, vestibular affecting their balance, or anxiety or mood. And then we also characterize these associated conditions like neck pain, which we call cervicogenic, and then sleep disturbance as well. And so by kind of characterizing each concussion into those different subtypes, we can then help to figure out, is there any additional intervention that is required? Usually that's only the case in situations where those symptoms are lasting beyond that normal recovery period. So again, adults 10 to 14 days, kids 28 days. So if we're approaching that threshold or we're already past it, then I'm much more likely to refer to various different types of providers to help manage this concussion. So for any patient that's having a lot of neck pain or having issues with their balance or eyes, I'm going to send to Dr. Crowe, our concussion specialist physical therapist, who's going to help to engage in some very nuanced rehab exercises to target those deficits. If they're having a lot of issues with school, loss of focus, concentration, persistent brain fog, usually that's when I'm going to refer to a neuropsychologist and consider speech therapy. If they're having persistent headaches, we will try some initial management, but if it's persisting, then we'll send to headache specialists or neurologists. If there's persistent eye issues that I'm picking up on the exam or individuals are telling me about, I'll send to specialized types of eye doctors. If there are persistent emotional symptoms, then it's very useful and helpful to get psychology on board, or at the very least, a licensed clinical social worker, a trained mental health professional who can help to address these affective symptoms. And then finally, with sleep disturbance or insomnia, again, we'll try some initial medical management, but if it's persistent, then I'll send to a sleep medicine specialist. And so just to kind of summarize, a concussion is a functional injury that causes many different symptoms. The number of diagnoses continues to increase, in large part because people are much better about reporting their symptoms, which is fantastic, and I would encourage people to continue to do so. Any player who's suspected to have sustained a concussion should be removed from play and evaluated, and should not re-enter the game or practice unless they are cleared. The majority of individuals will make a full recovery within a few weeks. Some student athletes will require some academic adjustments or accommodations to help with the return to school process. Athletes should not be allowed to return to play until they are fully back to school without issues and they are back to their baseline, they're not having any symptoms, and they have a reassuring examination. That light physical activity really does help to speed up recovery, so I would encourage people to get started on that. And then for those individuals that are experiencing prolonged symptoms, sometimes we do enlist the help of other providers such as CAT or other different types of medical providers to help tackle that concussion from a team approach. So without further ado, I think that's all I have for today. Sorry for running a bit over time. Happy to take a question or two now, but don't want to eat too much into Dr. Crowe's time.
Yeah, no, I think a lot of important information there. And I think the reason it is so much information to take in is that I know the way I grew up and the way concussions were dealt with, and now having young kids that are participating in sports, just even to be a volunteer coach this past fall, we had to take safe sport, and everything that I learned in safe sport from when I feel like, I had a concussion when I was younger, the way it's diagnosed and treated has come so long. So, we encourage our coaches and folks listening, there are resources like safe sport or things like that out there that we would encourage you to look into, just because that field has come so long and so far in the past, 20 years. So thank you very much. One quick question I think is pertinent here that I think a lot of people, as we have young kids in sports, have, is that one person asked here, my youngest child is transitioning out of flag football into town tackle football. I'm a little hesitant to sign him up. Do you feel like there's more concussions in youth football than any other sports?
It's a great question. The risk is higher in middle school athletes because typically these are kids that are still growing into their bodies. They have less control over their bodies. Potentially their necks are a little bit weaker. I would say that if there is one thing that should be most strongly encouraged at the youth level with football, is that the fundamentals of tackling need to be emphasized and are paramount. So if there is, early learning about how to properly tackle, as well as be tackled and potentially learn how to fall gracefully and avoid all of these whiplash type mechanisms when you fall, that can go a long way. But it is a reasonable question, and there's no doubt that football it's a collision sport, right? It is the highest the sport with the highest number of concussions that we see. So it's a reasonable concern. I would emphasize maybe some neuromuscular strengthening like Dr. Kowalsky was talking about, and then also an emphasis on learning the fundamentals.
Yeah, I think that's a great answer. Perfect. Thank you very much, Dr. Greene. So our final speaker tonight is Dr. Kat Crowe. Dr. Crowe received her doctorate in physical therapy from Ithaca College in Ithaca, New York, as well as her bachelor in science in clinical health studies with a minor in exercise science. She is a licensed physical therapist with special interest in neurology, spine, and chronic pain. She is experienced in acute and subacute rehab, concussion, and brain injury. She is a certified stroke rehabilitation specialist and a vestibular and concussion rehabilitation specialist. Dr. Crowe, thank you very much again for joining us tonight, and take it away.
Thank you very much, Frank. I appreciate it. And also thank you to Dr. Greene as well as Dr. Kowalsky for their great presentations. I apologize if I overlap a little bit on some of the topics that they discussed as well, but they all kind of interweave between each other. I also want to thank the Spire marketing team for getting this set up and helping us out to spread the word about injury prevention. Give me 1 second while I share the screen. I'm going to pull it up right now. Excellent. And there we go. All right, perfect. So my topic is specifically on sports injury management, specifically talking about physical activity management from youth to adulthood. As we already said, my name is Dr. Catherine Crowe. You can call me Kat. I'm a little bit more humble. So, so pretty much why is exercise important from a young age? So generally it assists with a lot of things. Those things can include strength, balance, coordination, also self-esteem and confidence. Those are essential components that come along with not only sports play, but also interpersonal relationships that come with being on a team. Similarly, especially at a young age, when you start exercising or participating in sports, not only do you learn how to do collaboration as well as have sportsmanship, but it also lays a groundwork for a healthy lifestyle. And generally, we see a lot of improvements in quality of life, mental health, illness prevention from a cardiovascular standpoint, as well as a musculoskeletal standpoint, and also increasing amounts of play. This allows children to be able to explore the world as they should, exploring outside of just the classroom setting where they're sitting from 6 to 8 hours at a time, and being able to go outside and participate in running around, playing games. All those things are essential for healthy growth of the child. Now, generally, when it comes to doing any type of exercise, regular to moderate vigorous exercise for kids and young adults varies between 30 to 60 minutes per day, about 5 to 6 days per week. This also provides significant improvements as listed above, what I wrote already in the slide. And children who regularly exercise are actually more likely to carry regular exercise and healthier lifestyles into adulthood. So there is that really essential carryover that comes along with exercising and also participating in sports. So let me kind of break down the fitness a little bit. So what you're going to be seeing here is that there's 3 different types of ways that you can look at exercise. So there's endurance, strength, and flexibility. So I'm going to break it down very simply, just from like a layman's term standpoint. So endurance is based on aerobic versus anaerobic. Aerobic means with oxygen. Anaerobic means without oxygen. So examples of an aerobic exercise are things like running, jumping, participating in swimming, anything that's like a long distance endurance activity. Whereas anaerobic sports or anaerobic activities are specifically when you are trying to take using less oxygen in a shorter period of time. So think of like high interval intensity based training. So anything that's like 30 seconds on at your most high intensity and then taking a break and then returning to that. Strength and conditioning training specifically means you're putting resistance on the muscles via weight. That can include body weight specifically, like Dr. Kowalsky talked about, especially for youth. You really want to focus more on their body control and ability to know where they are in space at a very much younger age than slapping a barbell on their back or giving them dumbbells, because it's really essential that they're able to control and have quality movement with their own body weight before you start adding on any type of resistance to it aside from their own body weight. With that said, similar to what Dr. Kowalsky said, that the more resistance training you add on for a child, or anyone for that matter, increases the muscles and the bones to get stronger. This concept is called Wolff's Law, meaning specifically that when you put tension on a ligament, a muscle, a bone, anything along those lines, it actually increases the strength of that muscle and increases the strength of that ligament or increases the strength of that bone over time, obviously within reason. And so examples of that can include weightlifting, any types of wrestling, which also kind of goes hand in hand with both cardiovascular and strength resistance training, gymnastics or calisthenics. And finally, flexibility. So stretching is a shorter term for that. This develops with both static and dynamic stretches. So a static stretch is the ones exactly what it sounds like. Static means to hold, meaning so if I bring my arm across my chest like this, I'm going to stretch the posterior or back aspects of my shoulder like so. Hold that for 30 to 60 seconds at a time, and it'll help lengthen the muscle. Whereas a dynamic stretch is more with movement. So you can think of dancers who are at a ballet bar. They're swinging their legs back and forth. They're twisting in certain ways because they are not only trying to increase the amount of blood flow to the area, but they're also trying to increase the elasticity of the muscles themselves. So this way it actually decreases the risk of injury prior to start of an activity. Major point of doing flexibility is the goal is to have full range of motion, or at least the amount of functional range of motion to be able to participate in the activity without it affecting your overall end goal during the activity that you're participating in. So examples of these could be Pilates, yoga, any type of general warm-up or cool down prior to or following any type of exercise. So exercise prescription, I'm going to break it down just right in front of me. I know Dr. Kowalsky already talked about this, so I don't want to repeat myself over, but children and teens should be participating about 60 minutes or more of moderate to vigorous activity per day. 3 days shouldn't always be 3 days, but 2 to 3 days or 1 to 3 days, depending on their age, should include some type of strength and resistance training. And again, similar to what I said before, really honing in on body weight training more than putting any type of dumbbell or resistance like with a barbell, because you really want that child to have good quality control. And you also don't want to put the skeletal muscles and the immature bones at risk of harm or fracture, for that matter. Adults 18 to 64 years old, 30 minutes or more of moderate intense activity per day, 2 to 3 days a week, should include some type of resistance training. And then older adults over the age of 65 is similar. The only thing that we start adding on after the age of 65 is really including some type of balance training. Generally speaking, balance training should be something that's incorporated even prior to age 65, but we know as we start aging and start getting older, balance does become more of an issue, whether that's due to visual changes, due to sensory changes, meaning where your body is in space, or even inner ear changes like the vestibular system, like Dr. Greene had talked about. So sports injury prevention is really essential. So maintaining hydration pre and post activity. So if your body is dry, you're not having enough fluid intake prior to an activity or following, you actually are at more risk of actually injuring yourself, because the elasticity of the muscle, ligaments, fascia within your body are going to be dried out, or they're not going to be as elastic. So it does put you at a higher risk for that occurring. Now, similarly, an equal balance, excuse me, my screen is acting funky on me. Okay, so an equal balance of water electrolytes, and including with the caloric intake, is very essential. So things like increasing your carbohydrates prior to any cardiovascular activity, including swimming or running, is great in order to increase the amount of strength or to increase the amount of muscle mass. Protein intake is essential, just like Dr. Kowalsky had talked about, and also having healthy fats in your diet too. Just so this way there's a lasting and sustained feeling full. And specifically, when you want to do any type of cool down, make sure that you just kind of walk it off, okay? You don't want to just go into an activity, be done with it, and then not cool down in any capacity, because you don't want to harm yourself in any way. So as an example in number 2 that I wrote here, dynamic warm-ups prior to activity can include things like jumping jacks, high knees, and walking lunges. Doing dynamic warm-ups prior to participating in any activity is more essential and actually very efficient at preventing injury to occur. It's actually better for you to do a dynamic warm-up prior to any type of activity compared to a static warm-up. The reason being is, like, I can kind of describe it as, think about a spring specifically. So with the spring, you can think about it, it bounces back and forth like so. With a dynamic warm-up, what you're doing is almost like you're lubricating that spring, so this way it compresses well and it spreads out well. When you do a static stretch and you just hold it like so, what you're doing is you're taking that spring and you're pulling it all the way across like this, and then you're elongating the muscles, which is great to do after an activity, because when you do an activity, the muscles and the fibers themselves are compressing back and forth like so, like the spring I was talking about. It actually puts you more at risk for injury to do a static stretch before any activity versus a dynamic stretch, because the dynamic stretch is going to simulate what it would be like to actually participate in an activity comparatively. Versus after any type of activity, you want to do a static stretch and cool down. Things like that can include quad stretch, which is the muscle on the top of your thigh, a hamstring stretch, which is on the back of your thigh, butterfly stretch, so putting your legs in crisscross applesauce and leaning forward, so this way you get some of the adductors, your inner thigh muscles, your lower back muscles, so on and so forth. That being said, I'm going to go next to my concussions. So concussion prevention, realistically speaking, there's no way to truly always prevent a concussion entirely, but there are better ways to practice to prevent them from occurring. So similar to the question that was asked to Dr. Greene prior to this, football is one of the higher rated sports where concussion can occur. Similarly, the other higher rate of concussion actually occurs with soccer, especially in female athletes. So Main reason for football, as we already know, there's a lot of contact with that sport. So people are constantly hitting each other, they're tackling, and that's what the requirement of football is, right? So things that we can do to help prevent that can include things like ensuring that your equipment fits properly, like the helmet is not too loose on you, your shoulder pads and everything are in place, avoiding unnecessary contact, specifically in cases where coaches are practicing with their children, or not children, but their students or their athletes for that matter. They should be participating in the least amount of contact that is necessary for them to be effective. So this would prevent any injuries from occurring prior to any matches or games, and also making sure that the safety and sportsmanship is really important and also honed in for these students and these athletes. Similarly, what I just said, so safe play during practices and games is essential. And then you can't hit what you can't see. So what I mean by that specifically in football, at least, and same for rugby too, is that when you tackle, you need to have your head up and you need to know where you're going, because there are two risks that you do with that. One, if you're going forward and you're going to tackle someone and you can't see what you're about to hit, you're not only at risk of injuring yourself, you're also at risk of injuring the other player, because you don't know where you're going to be hitting. You can hit below the belt. Above that point, you can cause not only injury to yourself, but also to the other person that's participating. Secondly, when you are able to see where you're going to hit, you can more effectively be able to move your body in a way that tackles the person as safely as possible, as silly as that may sound. But similarly, if you are not keeping your head up, what you can do when you tackle forward, and if you are looking down, is that you can cause what is a hyperflexion injury like that, and that can actually cause spinal issues on top of possibly a concussion, which can occur. And so other thing too is that with soccer, the main cause of most concussions in soccer is actually doing headers. So when the soccer ball comes towards you and a child, or an athlete in this case, jumps up and hits with the mid forehead right here, that is actually the number one cause of what causes a concussion in soccer, at least, usually due to whiplash injuries, just like Dr. Greene said. So the main thing when it comes to doing that safely is that you want to lead with the trunk and your core, so the abdominal muscles, and not with your head. Because if you go up with the force of all of it coming from your head, that is going to lead to a concussion. If you're stable in your core and your trunk, and you're using that force versus the force of your head, and you're transferring that momentum upward, that is the safer way to go about it. Similarly, you always want to communicate with your athletes and your other teammates that if you're going to do a header, let them know. So then this way, no one goes at you to try to tackle you in any way or try to block you. And then this way, they can also keep an eye on you. Say, God forbid, you do it incorrectly, or the ball comes at you in a way that is out of your control. Header sweet spot specifically is you want to look slightly beneath the mid hairline. So mine is right here, right about there. So dead center, right here is where you're trying to go for, just below the mid hairline. And then limp body versus stiff body. Okay, so a limp body versus a stiff body is actually better for you to be loose to jump up and to hit the ball, or a header in this case, versus a stiff body. When you do a stiff body, it actually tightens everything up and thus can cause you to have the whiplash injury, versus if you are smooth and the momentum is going forward, it can be transferred more effectively. And similar to what Dr. Greene had said earlier, removing a player immediately from the game if a concussion is suspected, always err on the side of conservative aspects. You don't want to risk putting a child or an athlete, for that matter, back into a match with the risk of them getting injured again. And something you don't want to happen is called second impact syndrome. I don't know if there are any football watchers here or people who watch Miami, specifically the Dolphins. Last year, Tui, the quarterback, had what was called second impact syndrome. He had the initial concussion that occurred in one of his games about a week or two prior, and then he had a second concussion occur after he had a faulty tackle occur to him, and it actually caused him to have actual spasticity in his hands, which is more of an indication of an actual brain injury or a spinal injury than it is just a standard mild traumatic brain injury, or a concussion in this case. Now, in the case of treating concussion, similar to what Dr. Greene had said earlier, there are multiple layers to a concussion. There's cognitive components, there's psychosocial components, there's visual components, balance components, and cervical components. When it comes to my area of expertise, I work with specifically cervicogenic, meaning neck, vestibular, meaning inner ear. I do a little bit of visual training. It's not my area of expertise. Usually I defer out either to occupational therapy, a neurooptometrist, or a neurobehavioralist. and then also the autonomic component of a concussion. So generally when I get a concussion patient, they don't usually fall in line with one specific area. They're usually not just one visual or one cervical based, or they're not one vestibular based. They usually have a concoction of all three together. So what I have to be able to do is make sure that I'm tackling all three of those areas and getting them to that symptom threshold. What that specifically means is that, similar to what Dr. Greene had said earlier, you don't want to cocoon a patient when it comes to the rehabilitation with a concussion. You want them to get to a point where they're having a symptom threshold where, say they come in to see me and their symptoms are a 0 out of 10, I want to provoke them to at least a 3 out of 10, because the more that we provoke the brain and stimulate the brain, the more we actually train it to get used to that stimulation. And then over time, they don't get as symptomatic with those activities. It's kind of similar if you go to the gym and you start running on the treadmill. You start with 1 minute running on, 2 minutes running off. Reason being, the more you do it over time, then it'll eventually turn into 1.5 minutes on, then 2 minutes on, then 3 minutes on, so on and so forth. So this way we retrain the brain similarly. When it comes to training the eyes or the inner ear with a concussion, what you want to look out for is how the eyes and the head are correlating with each other. As an example, when I turn my head to the right, in this case, it looks like I'm turning it to the left on the screen. When I turn it to the right, my eyes are moving to the left. When I go in the opposite direction, when I turn my head to the left, my eyes are moving to the right. This is how our eyes, brain, and inner ear correlate with each other to be able to fixate on things, such as when we're driving, windshield wipers going back and forth, people crossing the street, people driving. This is an essential component to be able to do, especially in sports where you're looking back and forth on a court. Tennis is a great example of that. Basketball is a great example of that. Soccer is a great example of that. Similarly, if you have a whiplash injury, what you want to look out for too is, are they having an overstretch issue? Meaning that is the stabilization of their neck the problem. So if someone has a whiplash, meaning they go all the way forward and come back up, all the muscles and ligaments in the back of your neck are being stretched out completely. In that case, what we have to do is the neck spasming in response to create more of a stability, or is the pain and the cervicogenic issues coming from the fact that the muscles themselves and the ligaments themselves have been overstretched? So now they're kind of feeling a little bit more loosey-goose. And similarly, the neck actually correlates very highly with the eyes. Usually if I have a patient who has cervicogenic-based symptoms, they usually also have an issue with their vision, meaning that either their neck is doing too much work to kind of accommodate for the visual deficits, or their eyes are doing more of the work to accommodate for the fact that their neck is very loosey-goose. This is the best way to describe it. So to spare us the time and the boredom, because there's over 600 muscles in the human body, and I could go through every single injury prevention and every single protocol that we could go through, I'm going to break down muscle strengthening and muscle movement by each component in a very similar way, and just try to save time as much as possible. Specifically, I focus on the lower extremity in this case, mostly because ACL and meniscus are the most common injuries that I tend to work with, and also tend to see in student athletes as well as young athletes generally. So breaking it down, a concentric movement versus an eccentric movement, without going into too much detail or expecting you to be also go through physical therapy or orthopedic school. A concentric movement is specifically the direction that the muscle moves in is the direction that the tendon is being pulled on. Meaning, if I take my bicep, which is right here, if I bend my elbow like this, I'm contracting my bicep. That is a concentric movement. It is moving in the direction in the same line of force as the tendon is attached to it. Move the muscle in the same direction, you get a bigger muscle. Eccentric movement is the quality control of that movement. Again, back to the bicep. If I have my elbow bent, my bicep is being activated. But if I slowly extend or straighten my elbow, I'm eccentrically controlling the movement at my bicep. So this way it doesn't over lengthen in any way. The best example of an eccentric movement is simply doing like a pull-up and slowly lowering yourself down. You're looking at the quality of the control of the muscle itself. So a concentric movement versus an eccentric movement, I think that's really essential to know the difference between the two. Is a concentric movement is you're going to be moving the muscle in a way that is going to increase the strength of it and the hypertrophy or the size of it. Whereas an eccentric movement is going to be looking more at the quality control of that movement in all directions in the full range of motion, meaning all the way up and all the way down. It has good quality control and not other muscles are compensating to make up for it. So in the case of ACL or meniscal involvement with lower extremity injuries, there are 4 major muscle groups that I tend to focus on just to minimize it for time. Those include quadriceps, hamstrings, gluteals, meaning your buttock muscles, and your core. So like on the screen, their quadriceps are the muscles on the top of your thigh. They assist with straightening your knee and also stabilizing your knee joint. And some really good examples of exercises to do for that are squats, split squats, also known as a lunge. A split squat and a lunge, the difference is that the lunge you are actually actively moving back and forth, whereas the split squat is you're just staying in position. Wall sits, bridges, and a leg press if you have access to that at a gym or any other location. The hamstrings are the muscles on the back of your thigh. Specifically, they assist with bending your knee joint, as well as also assisting with the stabilization of your knee from the posterior or back aspect of your knee. Those muscle exercises that could be include hamstring curls, lunges, Nordics, which is pretty much someone is holding you at your ankles and you are slowly controlling yourself to go all the way down to the floor and coming back up in a somewhat prayer position. A single leg bridge, and then deadlifts, which is if you have access to a gym or a barbell, that is equally effective. Gluteals or glutes are the buttock muscles on the tops of the back of your thigh, and they attach onto your hip joint. They assist in the movement of your hip and putting your leg behind you, kicking it out to the side, and also assist with hip and knee stabilization. A lot of the time, if I have a knee injury patient, I'm focusing heavily on their hip and in their gluteals, because the main stabilizer for the knee outside of your quads and your hamstrings, which are great because they attach on there, if your hip is not strong and not stable, it's not going to stabilize your knee either. And you might have more knee pain or more knee issues in the long run. So what exercises can make them stronger? Those things include hip thrusts, lunges, similar to what I said before, squats, which is also can be base quad heavy or glute heavy, Romanian deadlifts, which is just a term for a straight leg deadlift, band walks with resistance bands, or good mornings, which you can perform without a barbell and also without a dumbbell. And finally, your abdominals. So the abdominal muscles are multi-layered. You have a superficial layer as well as a deep layer. So the superficial layer is what you see with the six-pack. The deep layer are under several layers underneath. So you have your obliques, which are the ones that tend to show off your ribs if you have a lot less body fat. The rectus abdominis is the muscle that's on the top that usually shows your six-pack. And then your deeper muscles, which include your transverse abdominis, your multifidus, and your quadratus lumborum, those are all very deep muscles in your lower pelvis, both in the back and the front, and they are essential for stabilization of the spine as well as your pelvic floor. The main thing about the core in itself is that its job is not only spinal stabilization, but also to prevent spinal movement. So what we want to prevent is a hypermobility in one direction versus the other. So if you're thinking about core strengthening, which is better, static or dynamic core movements? Generally, doing any type of strengthening is beneficial, but when it comes to a young athlete, I would rather focus more on static or stabilization, because if you think about the core, it's meant to stabilize your trunk when you're moving throughout your day-to-day life. So things that can include that is planks, dead bugs, bird dogs, cat-cow, boat pose. These are all multiple named exercises that I'm not expecting anyone to memorize or know. But generally speaking, I think if you tackle all of these areas, prevention of injury in the lower extremity, as well as in the spine itself, these are good areas to start tackling on the first place, especially in a body weight position. And with that, we are good to go. And I answered pretty much, did everything for my presentation, and hopefully it collaborated and matched up with everyone else's.
Yeah, no, that was fantastic. We have one quick question in the chat, if you don't mind. Someone asked, why is stretching after training so important? What could we potentially damage if we don't do a proper cool down?
So there's multiple things that can occur with that. So I'll tackle the first question. So stretching after strength training is essential. I'm going to go back to that spring that I was talking about. So think about the muscles as multiple fibers that kind of lay on top of each other like this, similar to a spring that compresses back and forth. When we contract a muscle, we're compressing the spring. When we elongate the muscle or lengthen it, so stretching in this case, it lengthens it. We are doing strength training, resistance training, activities of any capacity. We're going to be consistently contracting that muscle over and over and over again. So you kind of think about it like a piston or that spring just consistently being compressed, 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 compressed. When you are done with your activity, think about this. If you're not stretching afterward, the spring is going to stay in that compressed position. And what that can lead to is adhesions to be built, range of motion limitations to occur. And if you're not stretching effectively and you're still consistently exercising at the same rate and intensity that you are without stretching afterward, that is what can lead to injuries, is that the ligaments, the muscles themselves are not elongating or at least going to the full range of motion that they're supposed to. Similarly, you don't want to skip a cool down, not only for the fact that it's beneficial for elongating and lengthening the muscles afterward, but cardiovascularly speaking, when you exercise, your heart rate goes up and so does your blood pressure. If you are working out and you have a heart rate, say at 125 or 130 beats per minute, and then you stop dead cold, it actually causes a cardiovascular reflex to occur where your blood pressure and your heart rate can tank. And then you get things like dizziness, feeling faint, shortness of breath. And so it's best for you to slowly cool yourself down to allow the muscles and the body to regulate themselves in the autonomic nervous system. And this way you feel more back to your normal self, and you don't risk injuring yourself, not only from the muscular standpoint, but also the cardiovascular standpoint.
Absolutely. No, a perfect answer. So thank you guys so much. Again, Dr. Kowalsky, Dr. Greene, Dr. Crowe. I know it's a lot of information for me and everyone else to take in. So we had another question in the chat about, will this be posted anywhere? And we're going to send the link out to everyone that registered. We'll also put it on our YouTube page. We know we had a lot of athletes and families that had fall sports tonight with all the rain, so many reschedulings, unfortunately. So we'll send that link around. Feel free to share it with your families, friends, teammates, what have you. Again, any more information that you want or want to reach out to any of the doctors or information you need on ONS, it's www.onsmd.com. And any information you need about the House of Sports is houseofsportsny.com. And for me personally, I value this partnership fantastically because we feel we have the greatest facility in Westchester County, some of the greatest coaches, and now that we have some of the greatest doctors, we feel that we're now a full 365-degree facility. So thank you all so much for your time. Not only to our panel, but all those that logged on tonight and joined us. So thank you all again.
Thank you, Frank. Have a good night.
Frank, have a great night.
Thank you, everybody. Have a fantastic evening.